An 84-year-old man presented to the emergency room after his wife found him to be behaving differently than usual. He carried diagnosis of hypertension, history of stroke, and mild to moderate dementia. The wife noted him to be hallucinating 3 to 4 days prior to presentation. Oral intake had diminished considerably, and he was found to have decrease in functional capacity. There was no history of fevers, chills, rigors, nausea, or vomiting. The patient and his wife had returned from Maine approximately 4 weeks ago, where they had been vacationing. There was no recent or remote history of travel outside the country. No changes were made recently to his medications. Physical examination revealed a pleasant elderly gentleman. He was hearing impaired at baseline. His vital signs included oxygen saturation were within normal limits. Patient was noted to be agitated, confused, and at times mumbling incoherently. The wife noted this was different from his normal baseline, which was forgetful but coherent. No icterus was noted, though there was minimum conjunctival pallor. Respiratory exam and cardiovascular exam was unremarkable. No focal cranial nerve deficits were noted, and there was no neck stiffness, nor was there any nuclear rigidity appreciable. Both Kernig's and Brudzinski's sign were negative. The patient would mumble incoherently, which his wife noted was new since he could talk at baseline. Tongue was midline. Examination of his extremities showed a bruise-like lesion on antecubital area of his left arm. Laboratory exam on presentation showed anemia with a hemoglobin of 10.7 grams per deciliter, thrombocytopenia with a platelet count of 144,000 per cubic milliliters. Urine analysis was completely normal. The patient did have hyponatremia at 127 millimoles per liter, with hypochloremia of 91 millimoles per liter, and the serum was hypoosmolar at 267 milliosmoles per kilogram. A computed tomography CT scan of the head done at presentation showed chronic white matter changes without evidence of infarctions, tumors, or organic brain lesions. Rapid plasma reagin RPR was negative. Thyroid stimulating hormone TSH was normal. B12 and folate levels were within normal limits. Through the course of the next 24 hours, the patient was unchanged. He at no point showed signs of infection. The white blood cell WBC count and temperature remained within normal limits. The hyponatremia corrected on hydration. The patient was seen by the neurologist who recommended an electroencephalogram EEG and a magnetic resonance imaging MRI be done. The EEG showed diffuse swelling consistent with encephalopathy, and the MRI showed old infarctions in the left frontotemporal lobes. Upon further questioning the wife regarding the bruise on the patient's left arm, the wife mentioned that this probably was a black fly bite that he had sustained during his trip to Maine about a month ago. However, nobody had actually seen the fly or other insect bite the patient. They hadn't sought treatment for it since it seemed to be improving without intervention. She was unable to describe the initial rash fully, but didn't note a central clearing or a bullseye configuration to it. Based on clinical suspicion, this gentleman underwent a lumbar puncture, and both peripheral blood samples and cerebrospinal fluid samples were sent for Lyme Western blot. Cerebrospinal fluid CSF chemistries were remarkable for an elevated protein level of 101 milligrams per deciliter with normal glucose. Cell count showed a WBC count of 43 per cubic milliliter with 83% mononuclear cells. Red blood cells were absent. Based on this, the patient was empirically started on ceftriaxone 2 grams once a day intravenously. Over the next few days, the patient's mental status was noted to improve. He was more coherent and awake, much to the delight of his wife. The CSF was negative for VDRL and herpes simplex. Both CSF and peripheral blood ELISA with reflex Western blot tests were positive. Lyme IgG via Western blot was negative. However, Lyme IgM via Western blot was positive for IgM antibodies against Borrelia burgdorferi antigen 23 and 41. Based on current guidelines for interpretation of serologic tests in Lyme disease, this was viewed as a positive serologic diagnosis. The patient improved considerably over the next few days and was discharged to an extended care facility to complete a 4-week course of antibiotics. Prognosis: altered mental status following infection with Borrelia burgdorferi. An